Thank you so much, Assalamu alaikum. It's a pleasure to be here. And I hope this is not a reflection. The surgeon is always called at the last. Should be. Okay. I am full-time faculty at Indus Hospital, which you can see there. This is Pakistan's first free paperless hospital. All our paper records and imaging is totally on computer. And we provide treatment different specialties. In orthopedics, we do all treatment free of cost. This is my evening practice in South City Hospital. Now, this is a very interesting relationship, the orthopedic surgeon and the rheumatologist. I like to think there's a partnership like a cardiologist with a cardiac surgeon or a nephrologist with a urologist. 10-15 years ago, these partnerships, at least in orthopedics, were more or less non-existent. But I'm happy to say that just by the fact that I was invited here by Dr. Kamran and given repeated reminders to be there by Dr. Atil, I'm hoping that the working relationship between orthopedic surgeons and rheumatologists continues to improve. Now, the best way to understand what an orthopedic surgeon can do for a patient with a rheumatoid disorder is to see what we can do. Now, this is the traditionally thought of role of the orthopedic surgeon as a carpenter. We love to put in large pieces of metal on broken bones. But if you look at the evolution of orthopedics, this was the role of the barber surgeons and surgeons in general. Orthopedic surgery did not have trauma, and it was part of orthopedics only in the last 100 years. Orthopedics means making a child who's crooked walk, ortho and peds. These are some of my patients. I do a lot of pediatric orthopedics, cerebral palsy, non-ambulant children becoming ambulant after multiple level soft tissue releases, as well as osteotomies. For example, dysplastic hips, having femoral and acetabular-side surgery. So orthopedics includes a lot more than just treating broken bones. Now, the role in rheumatology can be diagnostic, helping in the diagnosis of the patient, as well as therapeutic. A lot has been spoken about today about tuberculosis, and we see a lot of bone joint tuberculosis. And since in a lot of cases the primary manifestation of rheumatoid arthritis and tuberculosis can be quite similar, joint swelling, pain, fever, raised ESR, early erosive changes on the X-ray, there can be positive family history in both of these. And as steroids and DMARDs are immunosuppressive, starting them in a patient with tuberculosis would be disastrous. Now, in such cases, what we now offer is either arthroscopic or limited open biopsy to get a tissue diagnosis. We can get a tissue diagnosis, we can get a fluid aspirate, we can get tissue for culture, which can be bacterial, mycobacterial. We've also seen overlap with cases which have grown nocardia. Now, some people would argue with me that this is not actually an overlap because tuberculosis is usually monoarticular and rheumatoid arthritis is polyarticular. Well, we have seen a lot of patients with monoarticular rheumatoid arthritis in which the biopsy histopathology has come back totally conclusive and the patients have responded to anti-rheumatoid medication. But we've seen a few patients with polyarticular tuberculosis. One patient I saw about 6 months back, 10-year-old boy, both wrists, both knees, both ankles were swollen. He had low-grade fever, high ESR, positive family history of joint pains. I biopsied his knee and his ankle, and he grew mycobacterium tuberculosis in his culture. He had frank tuberculosis findings in histopathology. If that patient had been started on any medication for tuberculosis, we can imagine what would have happened to this patient. He's now improving. I'm not following up this patient. I don't treat pediatric patients with rheumatoid arthritis. Our pediatricians have to deal with that. But this is just a reflection as to the complicated interaction between rheumatoid arthritis and tuberculosis, which we see at least in orthopedic practice. This is tuberculosis of the shoulder. This is a very obvious example, huge swelling, but this 16-year-old girl also had swelling in other joints, and I was definitely not sure whether she has tuberculosis or does she have rheumatoid arthritis. She turned out to have tuberculosis. There was frank caviation in her shoulder when we did the surgery, and her cultures also grew mycobacterium tuberculosis. Fortunately, it was not a resistant type. We have grown multi-drug resistant tuberculosis from our bone biopsy, joint biopsy specimens. The therapeutic bit does not necessarily mean joint replacement. Therapeutic means surgical intervention. That does not mean joint replacement. Synovectomy is very important, and I think synovectomy is something which we also tend to overlook. There are patients, all of you must be familiar, who have been started on disease-modifying drugs, even given intra-articular steroids. Clear-cut case of rheumatoid arthritis. We're not talking about the patient with the overlap with tuberculosis, but they're not responding. A synovectomy, which is possible for the knee, easiest for the knee, can be done arthroscopically, but also possible for the wrist, shoulder, elbow, And don't forget tendon sheaths. Tendon sheaths, for example, they are not sometimes considered as being significant, but if we can do a synovectomy of a joint, we can do a synovectomy of a tendon sheath. And the typical example is the tibialis posterior tendon in the foot. Now, tibialis posterior dysfunction is responsible for a collapsing pes plano valgus, a flat foot deformity, in which the subtalar joint will then end up subluxing, and the talonavicular joint will sublux as well, and produce secondary osteoarthritis in this foot. If the patients are not responding to the disease-modifying agents, synovectomy at the involved joint, synovectomy of the tendon, which can be at the wrist, at the foot, at the ankle, these can reduce the disease burden as well as prevent ongoing damage. So it's important to remember that not all orthopedic surgeons will be doing just joint replacements. The advent of arthroscopic surgery has really made things better because most of these procedures can be done as a daycare setup. The patient comes in the morning, has the procedure, goes home, different samples are collected, sent for the appropriate kind of processing, and as the tests are available, the disease can be appropriately managed. Some images from some of my patients. This is not a very good image of virinodular synovitis. This is the one which I could take off the monitor, but some of our patients have synovitis which is almost blackish purple in color with hemostidine pigment in the cartilage. And this is what a pannus would look like arthroscopically. This is an early stage, and this is a close-up of the kind of shaving instruments we have. It looks pretty scary, but this is very small. It's about 4 to 4.5 millimeter in diameter, and these can empty the joint of all sorts of hyperplastic synovium within minutes, and the patient has tremendous improvement in pain and disability within 24 to 48 hours. Soft tissue releases. A lot of patients do not get the adequate amount of rehab. Not because that they're not advised to, but because most people don't want to get it or lack the motivation to go out and have it done. We do not have home visit physiotherapists who are really competent enough, unfortunately, and most people can't afford the good ones. They do develop a huge amount of joint contractures, and the most common ones which you see are at the knee. Patients just tend to sit, and when they sit, they get contractures of the hamstring tendons and the knee joint capsule posteriorly, and they end up with 90-degree flexion contractures. Now, this can happen with relatively healthy joints. Now, what do you do for a patient who has a relatively healthy joint and a flexion contracture? Well, serial manipulation casting under anesthesia, slowly straightening out the knee or whichever joint is involved, as well as soft tissue releases. This can enhance the mobility of a patient. This is not one of my patients, but this is just a reflective example. If I have a pediatric patient with synovitis, the joint is relatively healthy still, but the child has developed a flexion contracture.